Good afternoon, everyone. I would like to thank you for again joining us for another one of these COVID-19 talks. Today, we are going to focus on advanced care planning. And I'm really excited about this session. We have some wonderful panelists who will be talking with us. Dr. Hawk, Leonard Hawk, Dr. Maria Gonzalez, and Dr. Naushira Pandya, who we will introduce. I'll let them introduce themselves a little bit later. First, I want to go through some agenda items. If you go through the next slide, yes. I want us to, once again, start with the state of the state and then review some headlines and updates before our keynote presentation. If you flip to the next slide, Shane. So this is really just an update of where we are at currently in this country. We are over 1 million cases. This number is moving fast. I received this information from Johns Hopkins at 8:30 this morning, and the number has already grown. We've had over 58,000 deaths, and we are in the state of Florida. We're seeing some increased numbers of cases. What we have seen, if you go to the next slide, Shane, is that we're at above 30,000 cases, at 32,846 as of 6:30 p.m. yesterday evening. Deaths are over 1,000 in this state. What I've read this morning, though, is that as far as the trend that we're seeing, Florida is actually not trending as significantly as other states are with new cases and deaths. So that may be why we're seeing more conversation around opening certain things in the state of Florida. But as we know, and I think we mentioned on the last few sessions, in our nursing home and our post-acute long-term care environment, everything is different. So what I wanted to just review with you were a couple of headlines that I saw that greatly impact us. And if you go to the next slide, so the first is the FDA's caution around the use of hydroxychloroquine and chloroquine for COVID-19 outside of hospital settings. And this really came as we saw some of the clinical trials need to be discontinued and shut down because of unexpected deaths associated with the QT prolongation and rhythm changes that these drugs could cause. So, it's another caution that I think we were all aware of. And we talked about, I think for the several of our sessions, about the fact that you would have to have EKG monitoring, you would have to do this. So it is, once again, one of those things that comes down to a very individualized choice for your patient. But I wanted to make sure you were aware that this came across and hit the news really on Friday of last week. Another thing that I want to share with you was a story that our own AMDA, a significant leader in AMDA, Dr. Wasserman, was leading. I broke my own rule of not watching the cable news and saw him on a show on Friday night talking about expanding coronavirus testing. And what this article comes from the LA Times, and their Department of Health leader really said that, we were wrong in saying that we only need to test nursing home residents who've been exposed, and if we know that there was a worker who might have been exposed, they're now pushing to test all of the residents in the LA area. And it really makes me think about what we're doing, here in Florida, where we've seen, and I know that there was a press conference yesterday with our state governor where they were talking about sending in the National Guard into some of the facilities, but we still have significant testing challenges, as we all know. One of the things that I think that we could credit AMDA with it, alongside the American Society of Consultant Pharmacists, is that they've now pushed out a way to really track the hot spots that we're seeing throughout the country. And if you, the link here takes you to a heat map. When you go into that heat map, you can search by your zip code and say that your facility is a facility that is experiencing COVID-19 positive cases, and it helps to really just get a sense of where all the hot spots are so that we can advocate for medication, supplies, and personnel for that area. So I thought this was a great thing that I really wanted to share. It is on, a link is on AMDA's website. I'm going to definitely ask for us to have a link under our COVID-19 library as well, so that you can go in and select the facilities that you are working in that may require identification. And it's all part of the effort that we've seen that has come down to be more transparent. So we want to make sure that we're identifying those areas that are in need of supplies. So with that, and Shane, I want you to keep me honest. Do we have all of our panelists on the call?
I do not see Dr. Hawk yet. I'm going to reach out here directly.
Okay, so we will start with Dr. Pandya. And Dr. Pandya, I would like if you could just to give us I think everyone knows who you are, but just a brief introduction and tell us where your care setting that you most work in along this post-acute long-term care continuum.
Okay, thanks so much, Dr. Sanders-Cepeda. I'm chair of the Geriatrics Department, professor of geriatrics at Kiran Patel College of Osteopathic Medicine, and we have a combined long-term care and outpatient geriatric practice. So currently I'm seeing more patients in the clinic, but our faculty are divided amongst long-term care clinic and in an assisted living setting. And I've done obviously some work with AMDA and the clinical practice guidelines, and I'm past president of AMDA, and I'm still hopefully be involved in helping develop an advanced care planning tool for AMDA and for our practitioners.
Perfect, thank you. And Dr. Gonzalez, would you do the same? Give us an introduction and talk about where you practice at. If you could press *6, Dr. Gonzalez, so that we can hear you. And I believe she is still muted.
Yeah, I don't see her muted through Zoom. She looks unmuted through Zoom.
Yes. And we may have, can you hear me, Shane?
Yes, ma'am.
All right. Dr. Maria Gonzalez, can you hear us?
So Dr. Gonzalez, it looks like you're not muted through Zoom. Is there maybe a mute on your phone or anything else?
Unfortunately, we can't not hear you. So while we're waiting for Dr. Gonzalez, do we have Dr. Hawk on?
I still do not see Dr. Hawk, and I did send a text message.
All right, so we're going to do some heavy hitting with Dr. Pandya. So Dr. Pandya, while we're waiting for Dr. Gonzalez and Dr. Hawk, I wanted to ask you, and Shane, we can, once we get Dr. Gonzalez's phone working and get Dr. Hawk, we could go back to intros for them. But if we can advance to the next slide for the sake of time. Dr. Pandya, I know that we've been seeing some, changes in the conversation and the way that we've been talking about palliative care. I noticed and happened upon this from the Canadian Medical Journal about thinking about palliative care beyond ventilators and how we're talking and thinking about saving lives. And if you go to the next slide for me, Shane. There was also conversation about what the palliative care response needs to be. So my first question to you is, when we're thinking about the impact that COVID-19 is having, what is that impact on palliative care and in the life management, and what should it be? So if you go and put that question up for me, Shane, on the next slide. And if you could speak to that, Dr. Pandya, we would greatly appreciate it.
Okay, I see Dr. Gonzalez on the camera. Okay, so I think this is really the time for palliative care to really come to the forefront because the outcomes for older adults are so poor, and we almost need to think about discussing advanced care planning in a COVID-specific way right now. So I've been working with Dr. Gore, who's head of the Infection Prevention Committee, and you've had her on your webinars, about developing a discussion tool for practitioners, anybody in the long-term care setting, so that we can actually discuss advanced care planning in a more structured way, and any practitioner could use that tool. Because we know that outcomes for older adults are so poor. The largest Chinese study had 72,000 people, and they broke out over 80-year-olds, which were only 3%. But the mortality in that population was 14.8%, and between the 70 and 79-year-olds, it was 8%. But other studies show even higher mortality. And the study from Washington State in the nursing home population, where the median age was 83, the mortality was 33%. So I think we need to discuss palliative care in the light of that. And when critical care patients were studied, I think it's also in Washington State, mortality was 50% in those receiving critical care. Mean age was 64. And outcomes of CPR are very poor. And we know this, the case fatality rate is between 1/3 to 50% in recent studies. So I think that although we are fairly diligent about discussing advanced care planning in the long-term care setting, we need to be even more diligent, not just with exposed patients or patients who are in isolation or at risk, but with everybody. And I think with palliative care, there's an opportunity to let them know what we can offer for comfort and dignity. And I think we also need to include in that discussion what we now know of outcomes in older adults. And there's been there have been a tremendous amount of publications regarding that. So talking about outcomes is important. We need to recognize the distress and anxiety of patients and family members because of the lack of visiting, so the isolation. I mean, these discussions are happening remotely now for advanced care planning. So we need to first acknowledge that burden and then discuss what we know about outcomes in older adults. And then not to forget, we shouldn't just jump into do you want CPR or you do not want CPR. So this is where palliative care, of course, comes in whatever the decision is for that patient. But we need to address their goals, and then whether longevity is their goal or at the expense of quality of life, or whether they have certain goals and they would, prioritize quality of life rather than longevity at any cost. So I think the discussion has become complex, and yet we could really simplify it. So we're trying to work on a discussion tool. First, familiarizing people with what COVID is, what it can do, and now we know it can cause multiple systems disorders and vascular disease. What are the potential outcomes? And then we could tell family members and patients what we can provide in a positive way in the facilities as far as comfort oxygen treatment, pain medications, and then make an informed decision based on that, and then document our decision. So hopefully this kind of structured format will help us.
So and I definitely want to come back to the management of it, but can I ask, if you're having this conversation, are you talking about their chronic conditions that they currently have separately from COVID-19, or how do you bring that conversation together that if you contract this condition, these are your outcomes?
Yes,
can you walk us through that?
Yeah, it is important because you have to not only consider age, but you have to say, and you also have these chronic conditions, and we know that older adults with hypertension, kidney disease, or chronic lung disease, obesity, have poorer outcomes. So I think we need to bring it in together in the discussion. You cannot just discuss it by itself. And it's surprising. Last week I was in our geriatrics clinic. I saw a patient who has very advanced lung disease, but he adamantly wanted to be resuscitated and have every available intervention. And his wife, who I'd known, has COPD, and she was immediately ready to sign a DNR. And so values and goals can vary.
Dr. Gonzalez, are you able to hear us?
Yes, I can. Can you hear me?
Yes. If you would introduce yourself, where you, what setting you work in, and then I will definitely pose the same questions that I just asked Dr. Pandia to you.
Thank you very much for having me. My name is Maria Gonzalez. Currently, I'm working as a palliative care consultant in one of the largest hospital corporations in Central Florida. Prior to that, we were working in a continuum care retirement community, nursing home, and ALF, and some community care. So,
okay, and what do you think the impact that COVID-19 has had on palliative care and the life care?
Right now, the COVID-19 pandemic has brought on multiple elements in advanced care planning discussions that we prior didn't have to bring in. Luckily, in Florida, the surge that happened in New York State didn't replicate, but there were very important conversations that took place as a matter of folks with multiple comorbid medical conditions being affected with COVID-19. And at this moment, we are trying to guide our conversations in terms of the different circumstances that our older adults are facing in the context of COVID-19. The fact that family members and extended family, they have to be away is bringing a complete different set of challenges. And at the same time, the grieving process for those families are coming into place with more complicated grief for those family members. Right now, we are trying to explain very carefully the impact of the COVID-19, but we are very careful to acknowledge about the things that we still don't know. So basically, we are trying to use the tools that have been developed to try to come with prognostication tools for those patients and loved ones, but we try to be very honest and upfront to explain the things that we still don't know.
So, I thank you for that. Yeah, there's so much that we find out every day, and I is trying to filter all of those questions. I'm wondering, how do we do that given the constraints that we as healthcare providers are under? You know, how do we have a conversation behind a mask that's so personal, or even via telehealth? If both you and Dr. Pandya, whoever wants to go first, you know, I would love to get your perspectives on that.
I'll try that. So with telehealth has helped, at least in our system. I mean, I know everybody's working at this, but if you can have audio and video connection, and sometimes audio might have to suffice, we have to use what we can use. And it might need another witness if the consent for, let's say, do not resuscitate is obtained on the phone. Then if you want to document in your record, it might be better to have a witness. And I think we have to use communication with trusted family members, messengers. Even it might even be the home healthcare nurse is the only one seeing that patient, or obviously in the facilities we can use family members, even a charge nurse, somebody who knows the patient well can help be in that conversation. And the other thing is, I think the communication we have all along, even before a crisis, to decrease the isolation of patients is really important.
So from our part here, I will second what Dr. Pandya is explaining. Whatever tool that we can use, if we need to use the old-fashioned phone, we do, but if we can have access to audio and video, that tends to be a little better. But even the non-verbal techniques to approach our patients and our families, trying to present the information in the best way that we can, avoiding very technical terms, but explaining to the best of our capacity the situation as we evaluate it at the moment. And allowing those family members also time to process and to tell us how they are processing the information. Oftentimes, what we find from family members is that they get small pieces of the clinical picture, and it's not until they are able to understand the whole process where they can create a mental picture of what's going on with their loved one.
And
I know. Yes, go ahead, Dr. Pandya.
Yeah, I mean, there's so much information. So even as practitioners, it's a struggle to keep up with it. So I think we all have to resort to one or two trusted sites in our professional societies, or CDC, or you know, a journal that you turn to, so that we ourselves are up to date. Because I think, as Dr. Gonzalez says, the conversation will change as the treatment and knowledge about this disease changes. So our perceived and actual outcomes will change when we discuss with patients. And the other thing, to back up what Dr. Gonzalez is saying, is our communication skills are really going to be challenged, because we now have to explain this complex condition to people who have cognitive impairment, to visually impaired and hearing impaired patients. So it's going to really challenge our abilities. And I think in the long-term care setting, we need to enlist the help of the social worker, a charge nurse, somebody who's really familiar with the patient.
So to that point, how has the facilities that you're in been handling that? Is it now all hands on deck with advanced care planning? Everyone sort of talking about it? Are you seeing families approaching, maybe calling the attendings or yourself asking, should I make my mom a DNR? What has that been like?
I'm gonna go first. In my experience dealing with the COVID right now, we have been called to discuss goals of care. Some of the pockets of resistance is that there is this perception that at times you want to limit resources, and at times you want to be, people will perceive you as the so-called dead panel. So the task becomes to explain to loved ones including the patients, that our main purpose is to assure that the care that they are receiving is in agreement with the set of values, and that we are there to help them to advocate to get the care that they really want, but explaining what that means.
And I thank you for that, Dr. Gonzalez. I have a question about that a little later. Dr. Pandia, any thoughts from you?
No, I have nothing to add. I think we're being more diligent. Every person who has symptoms that could potentially be COVID, we're having earlier discussions. Even if you get a call from the nursing home, you suspect it might be COVID. Before you're certain, before you make a plan of what to do, it's important to have that conversation.
If we could go to the next topic, I wanted to just think about, and I'm very excited that, Dr. Pandia, that you're working on a discussion tool. I wanted to know how we develop the palliative care plan for these residents, both for the non-COVID-19 and if they transition. How does that look? Do we need to, I believe, and I'll go back to a session we had a couple of weeks ago with Dr. Foley, where we talked about the need to have extra medications in the crash cart and things for our palliative care plan. How do we develop that, though, so that we can treat those individuals in place, you know, both the ones who are COVID-19 and the ones who we don't really want to send to the hospital if they are declining from another condition?
Yeah, I think one of the important things, and we're trying to develop, we have developed this, it's not been finalized or published yet in the discussion tool, is to talk about not only what is the COVID, what can it do, what are the outcomes in older adults, and then what can we provide? I think patients need to know and families need to know what can we provide, so that they need to know we can provide isolation, we can provide oxygen, we can provide medications for breathlessness, for pain management, and we can also ensure that you have some contact with that patient. I think the contact is really important, whether it's going to be through FaceTime or through iPads or even through window visits. That we have to, that's all part of the plan. I think we have to reassure people that their family member will not just be there in an isolation bed and that's it, that they might be over-medicated or not attended to. I think we have to assure patients. And obviously that has to be implemented in a written plan of care. And this could be different in different institutions, but not only the written plan, but the team taking care of the patient, especially the nurses and other healthcare disciplines, need to be aware of what that plan is.
Any comments, Dr. Gonzalez, on this point as well?
Yes, ma'am. So as you develop your palliative care plan, making sure that your patients that are DNR status and do not admit to the hospital, that you have a clear line of communication. So all the care team is able to know that the patient is not supposed to be sent to the acute care setting. And the staff, all the ones involved, are aware that the patient needs to be kept in place. That is with the frequent changes in shift. And also, piggybacking what Dr. Pandia is explaining, make sure that there is a plan in place for loved ones to understand that patients are going to be cared for at any stage, that nobody's going to close the door and let their loved one to die. But also that there will be a way for those loved ones to be in contact with the nursing home resident during this crucial time. So they're trying to ameliorate this awful sense of isolation.
That's really important, because one of the complaints we get even before this COVID era was the poor communication between families and the care team, including physicians and nurses. Families will often complain that their calls aren't answered, their messages don't seem to be getting through. So I think we have to be more diligent. I mean, for the really sick people, it will mean like some kind of daily report and face-to-face contact, electronically, of course.
If we're reporting back to the families daily, how are we operationalizing that? I'm just curious to know, and if either you, Dr. Pandya, or Dr. Gonzalez, if you guys will have an example, if anyone on the call has an example, maybe we could talk about it a little later. Curious to know how that's going, because, you know, communication is always a challenge in the nursing facility. Yeah, I think that's in my more active days, those were the number one complaint. I do want to turn our attention to the role of pulse. I know Florida doesn't have a state-approved pulse, and it is really part of our wheelhouse now. We're the leaders for the state. Florida Medical Directors Association is the leader for the state for developing pulse. What do you see as the potential role that a form like the pulse form should play in developing an advanced care plan? And I'll start with you, Dr. Gonzalez. I know you're really close to this work.
So basically, as you very well said, pulse is not legal in the state of Florida. However, in the context of COVID, it could provide us a very nice framework to determine the level of care that the patient wants to receive in the nursing home. The current events have put like in the forefront that patients in the post-acute and long-term care setting are the most frail of all. Pulse is probably, in my humble opinion, the perfect tool that could be used as a framework to basically know the type of care that the patient wants to be able to move forward with a palliative plan of care that could be in agreement with the patient's set of values.
Yeah, I really have I don't have anything to add to that, to what Dr. Gonzalez has said. But even in the absence of pulse, let's say we're not implementing this, I think there's still no substitution for good communication. If your patient, you know, whatever form you use, obviously the Florida DNR form facilities have their own advanced directive forms, or families bring in documents that are notarized and kept in the chart. I think right now we're going to need whatever form of advanced care planning or advanced health directive we have. And sometimes the most important thing, because we might not have got any advanced directive from a patient, is who the healthcare surrogate is.
So kind of like going back to Dr. Pandya, those conversations are extremely crucial because those conversations will allow to put plan in place and basically make sure that your patient gets the care that they want.
The next subject I wanted us to talk upon was the one that you both have mentioned so far, the conversation. It is not dying alone. You know, what are we doing to help our patients so that their last moments are spent by themselves? The compassionate visitation, whether it's via, as you mentioned, Dr. Pandya in the window, or face-to-face video chat. Just curious to see what measures and what do you think about what we need to do around this? And I'll start with you, Dr. Pandya.
I haven't had any direct experience with a COVID patient dying, so I can't speak from any direct experience, but I think this would be the time when some kind of communication is really important, even if it's a voice that they recognize on the phone. A patient may be very lethargic, excuse me. The patient could be very lethargic, but even a voice they could recognize, or if they have a cell phone or FaceTime visit with a family member. That would be very important. I think dying alone is one of the biggest fears of patients and families because they can't be with them. And maybe also, if we can manage with staff, then I would suggest even a staff member or a nursing assistant or a social worker, somebody who knows the patient could be with the patient, so they're not alone.
Dr. Gonzalez, your thoughts?
So unfortunately, I have been in the place of attending for patients COVID at the end of life, and the feeling of being alone is very overwhelming. And as Dr. Pandia very well said, the patient, him or herself, may be in a situation where they are not completely interacting, but still listening to the voice of the family members and loved ones is extremely important. I understand that for the long-term care setting, challenges concerning the personal protective equipment and the visitation process makes extremely complicated face-to-face visitation. But whenever possible, the audio-visual or even the window visitation is extremely important. And if at the end none of that is possible, at least that the loved one is able to speak on the phone with the patient. We also need to pay attention as healthcare providers of each other as a healthcare practitioner. It could be very taxing in our families, but also in other fellow healthcare providers. Typically, our arena is not very well trained to detect burnout or extreme stress, but we need to acknowledge this situation as very stressful, war-like environment, and it could be very taxing, not only in the families, but also in our facility staff.
And
I would
sometimes,
imagine so.
sorry, Dr. Sanders, sometimes the nursing home staff are the family of the patient. We mustn't forget that. Because sometimes patients haven't seen family members for a long time and they may be isolated even before they got sick. So their family is often there.
So I wanted to ask you both if, the next question is a little bit controversial, but it was mentioned earlier. If you go to the next slide for me, Shane, yes. The question has been raised, and I've seen it raised more in critical care journals than in journals pertaining to geriatric and palliative care. But I thought maybe it was a time for us to just talk about it because we are seeing that people are thinking that we are removing people off of care and doing things. But the question, if you go to the next slide for me, Shane, is really, it stems from some lessons that we saw in Italy. So just to set it up, in Italy, we saw physicians, because of the overwhelming number of cases that they were seeing, have to make choices about who gets on ventilators. And it really is stemming or leading the conversation of fertility of care. Just want maybe some thoughts about what that means to us, what do we think about it, and where we should position ourselves when we're thinking about these types of conversations. And Dr. Padilla, I'll start with you.
Okay, so I think we have to look at what the data is, and a lot of data is being published, sometimes very quickly. And so we see that mortality in nursing home patients, case fatality, was 1 in 3 in the Washington state nursing homes. In the big Chinese studies in over 80-year-olds, it was almost 15%. And with comorbidities, it goes up. There's actually even more data. I'm just looking at something I have here, is that of all the patients who went to the ICU, this was in one study, 2 out of 3 patients died. Okay, and less than 1 in 10 were discharged. And then there's another study about COVID-19 patients who had a cardiac arrest in the hospital. Only 4 out of 132 survived, and only 1 recovered neurologically. So this was witnessed cardiac arrest in hospital where resuscitation was started quickly. So I think that gives us an idea in a more quantitative way rather than just talking about futility, which can be very emotionally charged. You know, what the potential outcomes can be in older adults. And so in our discussion tool, we're actually going to include some of this information. And then, you know, that would at least frame the discussion after you've assessed the goals of care. And I think futility aside, it's important not to use interventions that are not going to be beneficial at all. They could be very distressing. The patient could be very, very sick with, you know, very poor prognosis. And we haven't yet come to this situation, but there could be a time when resources could be stressed.
Dr. Gonzalez, any thoughts on this?
Totally agree with Dr. Pandya. The information needs to be framed in terms of non-beneficial information and the projected outcomes that patients, the older adults, will have once confronting the COVID-19 infection. One of the pointers from Vital Talk is to explain information to family members, not from the standpoint that we are giving up on the patients, but as Dr. Pandya very well points out, what are the outcomes and what kind of suffering your loved one will be involved in if we go through.
Right. Fortunately,
Thank you.
You know, fortunately, we're not at the stage of stressed resources locally, but you know, the conversation should not be framed in terms of stressed resources. It should be framed in terms of goals of care and what do we know so far on outcomes in older adults in the ICU setting, for older adults who receive CPR, nursing home patients, and we have that data is mounting.
Yeah, and I definitely agree with both of your comments. I think, you know, I guess my question to both of you, is it a time to make sure that we have updated everyone's advanced care planning in the facility? Like, should we be going room to room and having that conversation with every resident in the facility?
I mean, in my opinion, yes, a simple yes. It is time.
In my opinion, it has been time since before COVID-19. It's just that the COVID-19 has made the situation way much more acute. But quite frankly speaking, lack of appropriate advanced care planning plays a major role in hospital readmissions and folks receiving medical care that actually make them suffer quite a bit at the end of their lives.
And I think it's time actually for all of us to make advanced care planning decisions. I went to see a friend recently who wasn't feeling well, and I mean, I knew her well enough, so I asked her immediately whether she wanted CPR or intubation.
Yeah, I actually started having a conversation with my husband and kids, and it was a little traumatizing for them. Unfortunately, you know, when you see some of the statistics and you see people who've been impacted disproportionately in communities of color, you know, for me, that has been family members who lived in some of those communities. And I wanted to have a real open conversation with my kids about people who we may still lose and what happens if this impacts us. And it was a little traumatizing for them, but after that first statement, at least we got to the point where, you know, my husband was like, okay, let's talk about it. Let's make sure we know, because every interaction is a risk when you think about whether it's patient care or even just going to a local grocery store. I want to open it up to everyone so that we can ask questions, whether you want to do that by chat or take yourself off mute and ask. I did receive something from Deborah Dobbs, and I'm not sure if I have your designation, Dr. Dobbs, or correctly, I'm not sure, but it was a proposal that she wrote for COVID-19 advanced care planning when 8 of 12 Washington State patients died while intubated on a ventilator, and 4 others died at home because they had do not resuscitate orders. The time to death was only 1 day apart. Do you want to? I'm thinking that's more of a comment, but if you want to add any color to that, please take yourself off mute.
Okay, yeah, this is Deborah. I just, as you were talking about it, I mean, people, do they really want to go to the hospital and be on a ventilator? Really, that last point I made was education needs to be provided to people before they go to the hospital about really the outcomes of using a ventilator and being intubated. And how many people really, when they're intubated, aren't the figures real low of being extubated once you're on a ventilator?
They are low, I believe, at least in the New York City data, 80% of people died after being intubated. But I think we're learning more. Deborah, I would just say one thing, that for a person who is reasonably functional and where treatment might be a goal, the hospital could offer more supplemental oxygen or even BiPAP. Or even medication therapies that we might not so readily start using in long-term care. So I think that there is a role for hospitalization for people who are functional and for whom longevity is a goal.
Okay, that's good to know.
And the other thing is we're learning more probably from bitter experience. Before, just hypoxia was being treated and everybody was being ventilated, and now we're learning that maybe the ventilator settings are not that were typically used for ARDS are not appropriate for people with COVID pneumonias. There are different the spectra of COVID pneumonias. There's some behave like ARDS and some don't. So, and patients can tolerate a significant amount of hypoxia. So ventilation is not right now the first go-to treatment.
Yes. And with that, should we, as part of the symptom management, should we have high flow oxygen in our facilities if we're trying to keep people in place? Either Dr. Pandia and Dr. Gonzalez, the question is open to either one of you.
If the facility is able to provide those resources, by all means. In addition, if the patient, we need to keep in mind that older adults is a very wide-ranging group of people. So if the goal of care is for the patient to stay in place in the post-acute and long-term care setting, and they don't want invasive ventilator assistance, if we are able to provide the high-flow oxygen associated with having good amounts of opioid medication to treat the dyspnea, that will be very important for us to assure that our patients are going to be able to be comfortable. If the patient wants to try to be admitted to the hospital after we have explained the potential outcomes, patients should be able to get the care that they need. And the frame that I'm verbalizing this thought process at this moment is based on the fact that we are not in the place right now where we need to be worried or concerned about rationalizing resources. So we need to potentially have another type of conversations if we were in another type of setting and if our caseload was different.
I want to make a point that someone mentioned in our chat about high flow O2 could be considered an aerolizing procedure. So it would require full PPE and an N95 mask. I thank you for making sure we are aware of that. So does anyone else have any other questions, please? So if we don't have any other questions, I would like to really take this opportunity to thank you both, Dr. Maria Gonzalez and Dr. Naushira Pandya, for having this discussion with us. It was wonderful and very enlightening. Unfortunately, Dr. Hawk was postponed due to an emergency, but I just want to thank everyone who's been with us over these last, my gosh, I think 5 weeks of having these COVID-19 updates and discussions. Thank you for all of your questions. We will be back on May 13th with more conversations for you, just with 1 week reprieve. And, just thank you for everything that you're doing for our residents who are in the post-acute and long-term care setting, whether they are at home, in the nursing facility, or at an assisted living facility. We are really appreciative of everything that you are doing. We have formed the COVID-19 Innovation Task Force. If you want more information about joining, we will gladly accept it. We're looking to have our first official meeting next week. So if you're interested, please email Shane or Ian back and let us know so that we can count you in. I thank you all and have a great and wonderful day.
Thank you.
Thank you.